Hello everyone, welcome to another lecture, and today we'll discuss something about men, multiple endocrine neoplasias, and it is a very important set of syndromes that you have to remember, and a lot of questions are asked from them. So, men is told to be present when there are two or more endocrine system involvement, and it is an autosomal dominant disease. Okay, so you have to keep that in mind. Now, before we go into men, there is something I would like to remember you as meon. Now, what is meon? Meon is men or multiple endocrine and other organ neoplasias. So it is somewhat like a men mimic or a pseudo men syndrome, and the syndromes that are in meon are von Hippel-Lindau syndrome, Carney's complex. See, von Hippel-Lindau I have covered in my lecture of neurocutaneous syndrome, so I would like to request you to go there and watch this. So Carney's syndrome or Carney's complex, neurofibromatosis 1, again that is covered in neurocutaneous syndrome, Cowden syndrome, then McCune-Albright syndrome, and the last one is hyperparathyroid jaw tumor syndrome. Hyperparathyroid jaw tumor syndrome, JT syndrome. Okay, so you have to keep that in mind. With that out of the way, we will just start our discussion on men syndrome. So first one is men 1. This is also known as Werner syndrome, and it is associated with chromosome number 11, and men 1 is the most common men to occur in pediatric population. So what is the most common, what are the manifestations in men? So one is parathyroid adenoma. This is the most common clinical feature in men. The second one are NET or neuroendocrine tumors of the pancreas or of the duodenum. So neuroendocrine tumors are most common cause of mortality in men, and pituitary tumors. Now this is the second most common cause of clinical features, and amongst pituitary tumor, most common causes or the most common manifestation is prolactinoma. Okay, so these are a few one-liners that I would like you to remember initially. Now we'll go into men. So firstly, the most important component of men is parathyroid tumor, parathyroid adenoma. So these are the most common and earliest to occur. Okay, they are most common and earliest to occur, and the mean age of onset is more than 15 years. And there is chronic or persistent hypercalcemia. Now, the most favorite question of examiners is that how do you differentiate PTH tumor in men versus a sporadic PTH tumor? So what is the differentiation between PTH tumors that occur in men versus those that occur in sporadic tumors? So in men, there is 1:1 ratio of male to female, while in sporadic it is 1:3 ratio in favor of females. Okay, in this men syndrome, all four are involved, all four glands are involved, while here there is an isolated involvement. One is involved usually, Here all four are involved because this is a diffuse process. Men syndrome is a diffuse process, so all four glands are equally involved. Again, here there are increased chance of osteoporosis. Why? Because there is more extensive involvement, while there is lesser chance of osteoporosis. And again, as four are involved, this is multifocal and this is unifocal or monofocal. So these are the difference between the parathyroid tumor that occur sporadically versus in men. Now, the second most common involvement is pituitary tumor. Pituitary tumor. It is the second most common in men one, and it is more common and more severe in females. Okay, so in females it is more common and more severe, and the prevalence is around 30 to 55%. Okay, so in men one the prevalence is 30 to 55% and the mean age is 30 to 40 years, and more than 80% are pituitary macroadenomas. And as I told you previously that what are the most common forms, then it is prolactinoma is the most common pituitary tumor in men, followed by non-functioning tumor or non-functioning adenoma, followed by GH secreting tumors. So you have to keep that in mind that the second most common CNS tumor or pituitary tumor in men is non-functioning. Third and the most important component are pancreatoduodenal nets or neuroendocrine tumors, and this is the most common cause of mortality, in men. Okay, and the prevalence is 9 to 42%. You can remember it as 10 to 40%. It is more easier. 10 to 40%. The prevalence of NET is 10 to 40% in men. Now, these are the leading cause of death, and macroscopic nets are potentially malignant. So here we have begun with malignancy. So initial two were not potentially malignant. This is potentially malignant. And 50 to 70% of them, 50 to 70% are associated with lymph node mets, because as they are malignant, the most common way of spreading is lymph nodes, and it is not direct spread, but it is lymph nodes. And once they have metastasized, you can go for mTOR inhibitors or tyrosine kinase inhibitors. These pancreatoduodenal nets express somatostatin receptors, and they are multifocal. See, all the tumors in men are multifocal because it is a diffuse process, it is a genetic abnormality, so everything will be involved diffusely. And this pancreatoduodenal nets are hormonally active. They secrete hormones, or they secrete ectopic hormones, and the most common hormone they secrete are GHRH and ACTH. So it may lead to exogenous Cushing's disease. So they are hormonally active, and the common hormones they secrete are GHRH and ACTH. The investigation of choice is actually dotate PET or CT, dotate CT or dotate PET, but you can also go for endoscopic USG and MRI, and all that investigation, CT scan can be given, but the investigation of choice is this one, dotate. Now we'll go into the individual tumors of NET. So individual tumors of NET are gastrinoma, insulinoma, and glucagonoma. So first we'll begin with gastrinoma. So gastrinoma occurs in gastrinoma triangle that you have studied in surgery, and it is associated with Zollinger-Ellison syndrome. And around 20% of all patients having gastrinoma have men. So gastrinoma prevalence is very, very high with men. So if you have gastrinoma, you are likely to have men, rather than if you have men, you are likely to have gastrinoma. Now, it is extremely rare in less than 20 years of age, and lymph node mets are around 50% in all patients. Again, the difference between gastrinoma in men versus a sporadic gastrinoma is that in men, the gastrinoma is multifocal and it is small and multiple, while sporadic gastrinoma are larger in size, but they are unifocal. Okay. Now, what are the investigations which are suggestive of gastrinoma? So there are basically two investigations. One is basal pH of the stomach always stays less than 2. So pH is increased. Technically, pH value has decreased, but the pH is lower and lower, so it is more and more acidic. And fasting gastrin values is more equal to 10. It is 1000 picogram per ml value is suggestive of gastrinoma. So that you have to remember. Now, what are the poor prognostic features? Poor prognostic features in gastrinoma. So, Cushing's syndrome, endogenous or ectopic Cushing. Ectopic Cushing. Then the prognosis is directly proportional to levels of gastrin. So, higher levels of gastrin is associated with higher levels of mortality and morbidity and worse prognosis. Mets or liver mets, male gender, larger tumor. So these are the poor prognostic markers in gastrinoma. The next one we see is insulinoma, and this is the most common functioning pediatric endocrine tumor. The NET neuroendocrine tumor, most common pancreatic neuroendocrine tumor that is functioning in children. Okay, now if you expect that insulinoma is working, then you will have symptoms of hypoglycemia and something known as Whipple's triad. You might know Whipple's triad. So Whipple's triad is present in patients of insulinoma, especially the functioning insulinoma. And again, it is the age of onset is around 40 years. And again, it is multicentric or multifocal, and it is smaller in size. And the most common location is pancreatic, body, or tail. So the most common location is this. Now, the investigation of choice is 68 gadolinium dotted PET. But the gold standard investigation is this investigation cannot be beaten by any other investigation. So it is 72-hour fasting. But again, 72-hour fasting is very, very difficult in children. It is very difficult for children. You to keep children, fasting for 72 hours. So it is, though it is the gold standard, the investigation we go for is PET dotted, or you can go for ocreotide SRS scan. Okay, and the last one is glucagonoma. And the only thing I want you to remember in glucagonoma is that the hallmark of glucagonoma is necrolytic migratory erythema. Now here what happens is that this necrolytic migratory erythema occurs in groins and extremities, and it is the hallmark of glucagonoma. And that is the only thing you have to remember. Other thing that if you remember is well and good, is the most common site. Most common site is tail of pancreas. That's all. Now, there is a syndrome known as Werner Morrison syndrome, and it is a VIPoma. It is a variant of VIPoma, which is associated with the triad of watery diarrhea, hypokalemia, and achlorhydria. So this is the Werner Morrison or VIPoma that is seen in men 1. Now, what are the other tumors that you see in men 1? So adrenal tumors can be seen in men 1, and it may lead to primary hyperaldosteronism. It may cause cortical adenomas, hyperplasias, nodular hyperplasias, cyst, and carcinomas. And this primary hyperaldosteronism is ACTH independent Cushing. This primary hyperaldosteronism is associated with ACTH independent Cushing syndrome. And pheochromocytoma or the medullary involvement is extremely rare. It is the cortical involvement which is there. So hyperaldosteronism and Cushing's is there. And if adrenal tumor is more than 4 centimeters, it is indication for surgery. Okay, you have to operate the patient. The other tumor that we find is carcinoid tumor and thymic, bronchial, and gastric. Now, amongst this, the gastric is the most common carcinoid found in men 1, and thymic carcinoid is associated in men, adult men who smoke. And the markers of carcinoid, as you know, are chromogranin 1, chromogranin A, 5-HIAA. So these are the markers of carcinoid tumor, and thymic carcinoid are associated mostly in male who smoke, and the most common carcinoid seen with men is gastric carcinoid. Now, other tumors are also found like angiofibromas, breast cancer, lipoma, ependymoma, meningioma, but these are not very common compared to the other men syndromes that we have seen. Now, the next one that we should know is men 2, which was initially called men 2A, and here men 3. Now, this both are associated with chromosomal number 10, which is the RET gene, RET gene, the proto-oncogene that we study everywhere, and it is associated with the RET gene, both of them. And men 3 was initially called men 2B. Men 2A is also known as Sippel syndrome. Okay, now both of them, as you know, are autosomal dominant. That we saw, all men tumors are autosomal dominant. Okay, so what is the difference between them? So here there is medullary thyroid carcinoma seen in around 100% of the patient, while here also is nearly same, medullary thyroid carcinoma that is seen in nearly 100% of the patient. Here you see pheochromocytoma in around 50% of the patient, while even here you see pheochromocytoma in around 50% of the patient. But here there are parathyroid involvement. Parathyroid involvement is present, while here parathyroid involvement is absent. So this is the primary difference between men 2 and men 3 is parathyroid involvement is absent, and if it is present, it is around 10 to 20%. Now, what are the associated features in men 2 that are Hirschsprung's disease, cutaneous, lichen, amyloidosis? So these two things are commonly involved with men 2, while men 3 has a longer list. There is Marfanoid habitus. Now, if you say Marfanoid habitus, there is pectus excavatum, there is scoliosis, there is pes cavus. So all these are associated with Marfanoid habitus. Then there are neuromas, mucosal neuromas or neurofibromas. Then there is presence of cafe, Ewley spots. There is ANS, autonomic nervous system involvement dysfunction. So all these are seen with MEN3, and both of them are associated with mutation or abnormality of the RET gene. And we'll see all three tumors of both of them with together. Okay. So medullary thyroid carcinoma is the most common manifestation of MEN2 and MEN3. And it is the age of onset is directly proportional to the aggressiveness of the tumor. The tumor, the medullary carcinoma, occurs in C cells of the thyroid gland. So it occurs in C cells of thyroid gland. So it is usually associated with upper sided or upper neck mass. The neck mass is, on the upper side neck mass. Okay, and the clinical features are diarrhea, flushing, and there is increased calcitonin, serotonin, and prostaglandins. So these are the markers of severity or the disease progression. Now the most common site of METs in medullary carcinoma is cervical or mediastinal lymph nodes. As you saw, the markers of the disease are calcitonin or chromogranin. Okay, and the MRI should be done in each and every one of the patient, and the calcitonin level that is abnormal is more than 500 picogram per ml, and this is the most common cause of mortality in MEN3. The next one is pheochromocytoma. As we saw, it is 50% seen in 50%, and it is in 50% of those 50%, it is bilateral, and 4% of the patient have malignant pheochromocytoma. Now urinary metanephrine is the investigation of choice in patients of the patients of pheochromocytoma. We do metanephrine screening, and usually the tumors associated or the pheochromocytomas associated with von Hippel-Lindau or other syndrome, they are significantly epinephrine. See, usually they are epinephrine secreting. But in von Hippel-Lindau, they are noradrenaline secreting. So you have to see urinary free metanephrine, but if you go for other investigation, it is actually normetanephrine that you see. Now the last one is MEN4. It is an autosomal dominant disease associated with chromosome 12. So I'll just help you revise MEN2 and 3, MEN4. So MEN1 is associated with chromosome 11, MEN2, 3 with 10, and MEN4 is with chromosome 12. So the chromosome associated with all three are summarized over here. And here the parathyroid involvement is the most common. Pituitary is the second most common, and PNETs are the third most common. It is nearly same as MEN1. Now, with this out of the way, we will see one disease that I need you to remember is Carney's complex. Now, what is Carney's complex? It is an autosomal dominant PRKARIA gene which encodes PRKA enzyme that is deficient in patient. So what happens is they present with lentigenes. What are lentigenes? It is like the spots on the leopards. So these lentigenes are present. They are small pigmented cutaneous or mucosal pigmentations, and there is cardiac myxoma. There is primary pigmented nodular adrenal disease. There is nodular goiter. There is pituitary adenoma. And these are the features of Carney's complex. Von Hippel-Lindau syndrome, neurofibromatosis, I have already covered in neurocutaneous lecture. And Cowden syndrome, you will see in surgery. So I hope that's all for today, guys. I hope you remember all this. And I'll see you in the next one.